Welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller, consultant editor for the journal. Well, every fall on the JOP podcast, we cover the annual National Practice Benchmark Report from Oncology Metrics. And for the fifth year in a row, I'm pleased to welcome back Tom Barr and Elaine Towle to discuss their 2014 findings. This highly anticipated benchmarking survey provides important and meaningful data for oncology practices to use in managing today's challenging practice environment. You can find the full report in the November 2014 issue of the JOP. As always, this report is packed with data with 95 separate figures in the manuscript. This is one podcast where I would encourage listeners to pause and grab your JOP issue or look at it online at jop.ascopubs.org so you can see the beautifully visualized data while you follow this recording along. Let me introduce Elaine and Tom, who will provide some perspectives and commentary on the 2014 NPB report. Elaine Towle is a former oncology practice administrator. She joined Tom Barr at Oncology Metrics in 2004 and recently started working for ASCO as Director of Analysis and Consulting Services in the new Clinical Affairs Department. Welcome, Elaine.
Well, thanks, Bob. It's always a pleasure.
Also on our Skype call is Tom Barr. Tom started Oncology Metrics in 2003 and began peer-to-peer benchmarking for the Oncology Circle in that same year. Both Oncology Metrics and the Oncology Circle are now owned by Flatiron Health, and Tom is also now working for ASCO in the newly formed Clinical Affairs Department. And welcome to you, Tom.
Thanks, Bob. It's great to be with you again. 5 years has gone by quickly.
Who would have known? So let me get into your report. You mentioned that, as I think you have in the past, that for a practice to successfully complete the NPB survey, the practice has to have pretty exceptional managerial capability. How would you characterize your 59 successful participating practices this year? And I think this is the first time you've actually listed them by name.
Well, you're right. This is the first time we've listed them by name, and we really did that very intentionally. First, to complete the national practice benchmark, practices have to have both the desire and really the courage to actually compare your performance to others. That's not always easy. Everyone who submits data has this attribute. And while that's really necessary, it's not the only thing. You also have to have the ability to actually count what needs to be counted and then report that data in the correct form. We had about 100 practices who had the desire and courage to participate, but the 59 that you see listed in the report are the ones that had that additional skill of actually being able to accurately count and report their data. Over the last, about 3 years, we've really begun to realize that this managerial capability is not all that common. So we wanted to recognize both the practices and the individuals as really being exceptional and having this exceptional managerial capability.
Sure.
These practices are not just in one business environment, but operate in a wide spectrum of environments and really do it with grace and acumen, which is what led us to actually publishing their names and their practice names in this year's report.
That's great. Great idea. So how about the instrument itself? Is this basically the same survey you've used in the past, or has the tool evolved in some way over the years?
Well, yes and yes. It's basically the same, but every year we try and refine elements of the survey, particularly the definitions, in order to increase data comparability. This year we eliminated many of the qualitative questions that are addressed in other surveys, including the ASCO census. So we've tried to keep the survey more quantitative than qualitative. And in some areas, we've reduced the granularity, kept the questions a little broader, because we realized that we just didn't have the ability to make any meaningful benchmarks from that really granular data that was submitted. This is designed to be a really living tool that reflects market changes, so we do make some changes every year in the survey itself.
You referred to the ASCO census. That's the ASCO census of oncology practices in the U.S.?
That's right. That tool really asks a number of qualitative questions that were duplicative of some of the work we had done. It's kind of a chicken and egg. We were both asking the same questions, so we decided to eliminate those from the National Practice Benchmark this here and really focus on the quantitative data. It's also, some of the changes have been made to try and recognize that this really is a small data set. So you can't get too granular with the data because you just don't get anything meaningful from that in a small data set.
Sure, that makes sense. Let me ask Tom, just for some clarity about this one metric. You talk about FTE hem-onc physicians and standard hem-onc physicians. What's the difference between those two?
Well, thanks for asking that question. The distinction between the two is very, very important. A full-time equivalent physician, an FTE physician, is really a very subjective measure. And because of that subjectivity, there's variation in how people really respond to that number. And that makes it a very poor denominator. When I say poor denominator, I mean you can't use that denominator across the broad spectrum of different practices. So the FTE is really a count of the number of people, of the bodies, and then you multiply that times sort of a judgment of effort. And so that's why you get that variability. Now, the standard hem-onc is an objective measure of work production. So it's derived by taking the total work RVU produced in a 12-month period and divide that by 7,000. So we've come to determine that 7,000 is a good measure of the standard work output of a hematology oncologist in a year. Since the work production of the hem-onc drives many of the resource demands and therefore the costs and the revenue for the provision of clinical care, the standard hem-onc is really an efficient denominator that you can use across lots of different practices of varying sizes and varying labor efficiencies. It's really a much more precise tool for benchmarking, and we encourage everybody to really think about that standard hem-onc as opposed to just counting the noses in your practice when you're measuring and benchmarking various things.
Got it. That makes a lot of sense. Let me get into the report itself. I had a few specific questions I just thought I'd run by you. Let me ask Tom first. I thought it was interesting that physician-owned practices were 83% of respondents, and that's compared to 80% in 2013. So I guess that means, or does it mean that the business model of physician-owned practices really isn't going away like everyone was predicting a few years ago?
Well, certainly there are some community business environments that do favor and continue to favor hospital affiliation or even outright consolidation of physician-owned practices. But there are others that don't, other business environments that don't. I think we'll probably continue to see a variety of practice business models in the oncology space, at least for a while. I heard a great comparison a few days ago. It said mass extinctions happen, but they really do happen only very slowly. So if we're going to see this extinction, it's going to take years, not just a year to happen.
The other thing you focus on the last couple of years, I think, was about the oral cancer drugs, which, of course, are increasingly important in oncology practice. How prevalent are these practice-affiliated pharmacies or dispensing units? And what did you learn about physician satisfaction with the specialty pharmacies?
Well, about 3 years ago, in the Companion Trends article that we publish every year, we predicted that the provision of oral cancer agents and the management of those agents, including things like patient compliance and side effects, was an important consideration for oncology practices in any business model, but was really kind of being focused on only by the real forward-thinking practices at least 3 years ago. Subsequent data reflects that the adoption of orals into these business models has increased, especially in the physician-owned practice. Unfortunately, payment methodology and manufacturer distribution strategy is not generally supportive. There's still a lot of pharmacy benefit management systems out there, but it really is something that is increasing in the physician-owned practice. In the report itself, in Figure 6, it shows that just under half of the survey participants have a closed-door pharmacy, which we define as one that allows patients and frequently practice staff to get their prescriptions filled at the practice, but it's not a pharmacy that's open to the general public. About 1 in 5, 20%, have a dispensing unit, which is another form of dispensing within the practice. And these are really the two primary models for dispensing oral medications. State pharmacy regulations, of course, have a lot to do with the feasibility of supporting office-based pharmacy, and that would be the first consideration that I would suggest that practices consider when they're thinking about this model, is make sure that your state pharmacy laws support this.
Got it.
And then you asked about satisfaction.
Yes.
And in Figure 5, we show that satisfaction with the clinical services offered by specialty pharmacy is pretty low. And that's one of the drawbacks and one of the complaints that practitioners and practices generally have with specialty pharmacy. They embed, specialty pharmacies embed their own clinical services into the patient process, and practices aren't very happy about that in general. But it was interesting that only about 20% of our respondents didn't know how to rate the service, so it hasn't become a big issue for them. But for practices that did respond, they're not happy with the clinical services offered by the specialty pharmacy, generally because they feel it interrupts the patient service with the practice.
Yeah, certainly. I've heard that anecdotally. So let me ask Tom about productivity. What were your physician productivity statistics for 2014 for new patients? And again, can you explain this HEMONC capacity ratio concept?
Sure, happy to do that. We talked earlier about a HEMONC capacity ratio that's based on the number of work RVUs that are produced. And that's one that we use a lot. But you can also do a HEMONC capacity ratio based on the number of new patients that are coming into the practice. In fact, the number of new patients entering the oncology practice is really a key indicator of sustainability of the business unit, kind of for obvious reasons. It's really a very good, sensitive measure on the demand for services and predictive of future demand for services. So for a good many years, we saw this number around 280 new patients per year per HEMONC physician. But then in the past 5 years or so, we've seen that number really kind of go up and then hover around 350 new patients per year. And so we use 350 new patients as the standard. So a standard HEMONC based on new patients will see 350 in a year. In the 2013 data, it looks like the average has really backed down a bit from that 350 number to about 300 or so. So based on the concept that 350 new patients is that we've seen in the past is really a benchmark for what is capable, and still seeing that number at the 75th percentile in the 2013 data, it really leads us to believe that there is additional capacity in the body of existing physicians to see more new patients. And in fact, we hear in many marketplaces that the competition for new patients coming into existing practices is quite keen. And so there's reason to believe that capacity really does exist out there. So the HEMONC capacity ratio can be calculated, as I said, on new patients or work RVUs, and both of those calculations produce a standard output in the denominator and the observed output in the numerator. So by way of example, suppose I'm a very popular oncologist and I see 700 new patients in a year. So that 700 would be my actual, production, but that goes in the numerator. 350 goes in the denominator. So I would have a HEMONC capacity ratio of 2, meaning that I'm seeing twice as many new patients per year as the benchmark standard. But further, suppose that while I'm getting all these new patients, I really like to play golf more than take care of them. So I delegate their follow-up care to my team of trained clinicians. And so I'm only really getting the work RVU content for those initial assessments, and a lot of the work is being done by my partner. So say I only got 2,000 work relative value units per year. So my capacity ratio based on work RVUs would be 2,000 over 7,000. So now I'm only about a 0.28.
I see.
Physician. So that's how you can use those numbers to really calculate the productivity of your physician component of your staff.
And it looks like you saw a range of those ratios in one of the tables.
Yes, and we do see quite a range of ratios. As we think about those ratios, this is a great example of where you really are looking not at the middle, not at the mean, not at the average, but you want to be looking at what are those folks at the 75th percentile, the 80th percentile, what are they doing differently that enables them to be so very productive. That's where the learning takes place.
What about expenses, Elaine? One of the figures, figure 22, shows a breakdown of practice expenses. And I thought it was interesting that, and I guess not surprising, that 53% of the expenses were for the infusion pharmacy, but less than 20% were for physician and staff pay.
Well, you're right. This is a really important observation, and it highlights the fact of life for medical oncology practices that drugs are very expensive and indeed the largest expense for the practice. This hasn't changed over time. We also encourage everyone in the industry to consider drug costs to be cost of goods, to use an accounting term, and to reduce total drug revenue to net drug revenue when you're considering drugs. So take your total drug revenue minus the cost of drugs to come up with a net drug revenue. Doing this really adds clarity to the whole medical oncology business model, and you'll see we've moved to that model in our reporting, and we encourage others to do that as well.
Now, on the revenue side, you give a breakdown of components in Figure 40, and there were some interesting bar graphs, Figures 29 and 30, related to or about the relationship between net drug revenue and total or net medical revenue. What were your findings in that area, Elaine?
Well, the real takeaway is ties to what I just said, that the net drug revenue is a far smaller component of overall practice revenue than gross drug revenue. And thinking about gross drug revenue really distorts your thinking completely as far as both expenses and revenue are concerned. Also remember, even once we come up with this net drug revenue, which is really just netting out the cost of drugs, there are still lots of costs to be paid out from that before we can get to any contribution to the bottom line from the whole buy and bill component of the business. Inventory management, mixing drugs, handling drugs, bad debt, the whole issue of safety adherence, those are just some of the costs that must be covered from the net drug revenue. So it really contributes, the contribution of drug revenue to the bottom line is much smaller than you would think when you first look at that gross drug revenue number. We're really encouraging practices to think about it in a very different way.
Now, you really expanded your benchmarks this year looking at radiation oncology. Can you talk about some of the findings in the radiation oncology area that you'd like the listeners to know?
Sure. Radiation oncology has been something we've tried to do for a number of years, and a few years ago felt like we really came up with some meaningful metrics, but we still consider that we're pretty early in the development of these metrics for radiation. The variability of the business structures and the complexity of the reimbursement models in radiation oncology make it difficult to come up with widely applicable benchmarks. I frequently say when you've seen one radiation business model, you've seen one radiation business model. They're so different as far as partnerships with hospitals and other entities. But we do think we've come up with a reasonable definition of a standard radiation oncologist, kind of modeled after our work in medical oncology. And we report that based on 26 treatments per day. And that's a number that has held up pretty well in the test group of radiation practices that we've worked with. So that provides us with a denominator. When we look at the expense and revenue as numerators in this analysis, though, we really see that the complexity of the therapy, which is really determined by the availability of the equipment as well as the clinical indications for therapy, is a really powerful driver of both expense and revenue. So that leads to wide variation in these benchmarks per standard RADON. This is clearly still a work in progress.
Now, in this same issue, you authored a second paper analyzing the trends in the NPB data going back almost 10 years for some of the data, I think. Let me ask Tom for comments on two of his observations that I gleaned from this. The first is that total medical revenues seem to have stabilized from the years 2011 to 2014, despite some of the ominous signs to the contrary that we saw post the Medicare Modernization Act, the period from 2005 to 2010. So I'm going to ask your comments about that stabilization. And the second very interesting statistic you noted is that physician productivity seemed to go down a little bit this past year. What do you think these two things are telling us?
Well, thanks for asking that question. I like a chance to talk about that. As you know, and your readers would know from the Trends articles, we've come to look at the oncology delivery system really in terms of an ecology, trying to apply ecosystem sort of thinking about that. So we see it as an adaptive, self-regulating complex of interrelated kind of living organisms. And in this model, the individual practices are the living organisms that we focus on. So when the system is stressed and the organisms feel threatened, then their response is to fight or flight. So in the prior years when chemotherapy margins were plummeting, there was lots of stress. So the fight means that practice sort of would buckle down and learn how to get more productive and more efficient. And that's when we saw those numbers get up to 350 new patients a year, and work RVU went up and staffing went down. So that's the fight response. The flight response was that folks would look around and find a safe harbor. Perhaps that's a hospital or a bigger practice, something that would let them get away from that perceived danger. But then we saw sort of a moderation. The threat condition resolved, and really kind of the low margins on chemotherapy became normal. And so that got baked into our expectations and our production. And so that just became the new business of the day. Expectancy and perception are the real drivers of change. So in periods of stability, you don't get that kind of change. So I think it really is like a response and a threat and a response and a threat. So round and round it goes. When we see that there'll be new threats, perhaps they'll change, the chemotherapy delivery system will change completely. Perhaps we will someday move from a fee-for-service to a pay-for-value. Those will be perceived by threats. There'll be responses, and there'll be adaptation to it.
Tom, I ask you to predict the future every year, and I promise I'm not keeping score. But what about 2015? Do you have any key predictions?
Yes, I think the 2014 data, which we'll see in 2015, is really going to look a whole lot like the 2013 data. That is that this relative calm period will continue. We're not going to see anything real dramatic out there. In fact, I don't see another game changer really coming along until there are some big changes, say, to 340B. That could shock the whole system one way or another. Or perhaps increased regulation of the safety standards for chemotherapy handling. These could become much more stringent and be another cause of major change in the ability to provide cost-effective chemotherapy infusion. But none of those things happened last year, so we won't see that in the 2014 data. But those are threats, really, I think, for another time period.
Any additional insights from your data that you'd like to share with our listeners?
I finished the trends paper with a quote from William James. William James was a Harvard-trained physician. He was one of the leading thinkers, really a dominant thinker in the late 19th century, and is now considered to be the founder of philosophy of pragmatism. I think we see pragmatism around us in our political system every day, the art of what's possible. And he said about, when he starts talking about trend analysis in general, his quote is, "New truth is always a go-between, a smoother over of transitions. It marries old opinion to new fact, so as ever to show a minimum of jolt and a maximum of continuity." I think that's the very definition of adaptation and the embodiment of resiliency, this bridging mechanism to accommodate new facts that we see and get them aligned into the old ways that we have of dealing with them. So I think that's really about the best summary that I could have about our data and insights from it. And I hope that comes across as a kind of an optimistic way of looking at things. Maybe a shorter version is the more things change, the more they stay the same. We'll get by. It'll all work out.
Very comforting. Very comforting. Well, Tom and Elaine, as always, on behalf of the JOP, thank you for your monumental effort of putting this report together that's so helpful to oncologists, and for sharing your interesting data with our audience on this podcast.
Well, it's our pleasure. Thank you for the opportunity again, Bob.
Yes, I'll agree. It certainly is always our pleasure, and we are happy to do it. Look forward to sharing in the future.
And thanks again to my guests, Tom Barr and Elaine Towle. As I mentioned, this is one JOP report you don't want to miss, so check out all of the tables and graphs in the November issue or online. And don't forget that you can read the JOP on your iOS or Android smartphone or tablet with the ASCO Journals mobile app, available in the iTunes Store and Google Play. This is Dr. Bob Miller for the Journal of Oncology Practice. Thanks very much for listening.